is Megan, and today I will be presenting my pathology case study. Okay, so let's talk a little bit about patient history. So we have a 47-year-old male with no priors that comes in for an abdominal ultrasound. He says that he's been getting headaches, he's been sweating, he has heart palpitations, and a tremor. He said these symptoms started a couple of years ago, but they've become more frequent. They can last anywhere from a few seconds to up to an hour. He said that it mostly happens whenever he's stressed or like after he exercises. He doesn't have a history of any type of serious illnesses or hospitalizations or any sort of trauma. He's not on any type of medications. He has a family history of hypertension. He doesn't use any tobacco products or drugs, and he did not have a fever or any signs or symptoms of nausea, vomiting, or diarrhea. On his physical examination, however, he did have high blood pressure and tachycardia. When he had his labs drawn, everything came back normal except for his urine test. His urine test came back with elevated levels of catecholamine and metanephrine. Okay, so let's look at some imaging. So here we have a couple ultrasound pictures and then we have a CT. So in these ultrasound pictures, you can see that we have a heterogeneous mass with smooth borders. It's adjacent to the liver. It seemingly occupies the same space as the kidney, and it is hypoechoic to the liver and it is isoechoic to the kidney. Here you can also see color flow in it. On the CT images that were obtained, you can actually see that the mass is on the superior pole of the kidney, but not actually attached to the kidney itself. So how would I describe this as a tech? So first and foremost, both of our kidneys were within normal limits, as well as our aorta, bladder, and prostate, so no need to comment on any of those. It was just this mass on the right kidney. So I would say there was a solid mass that measured this much or however much it measured, and then I would describe exactly where it was seen and be specific as possible. So in this instance on the right kidney, I would say it was seen medial to the superior pole of the right kidney, and then it was inferior to the liver, and then I would describe the echo texture as being isoechoic to the renal cortex and hypoechoic to the liver parenchyma. And then I'd also mention that color flow was seen. So with all the information that I've given you so far, what do you think is the diagnosis? If you guessed pheochromocytoma, you would be correct. So to fully understand this pathology, I think it's important to look at the gland in which it's originating. So for this pathology in particular, it will be your adrenal glands. So I would know that your adrenal glands sit on top of your kidneys. They're also called the suprarenal glands for that very reason. Your adrenal glands produce different types of hormones that regulate your metabolism, your response to stress, your blood pressure, your immune system. It is composed of two different parts. So you have your cortex and your medulla. So your cortex is the outer part. You can think of it like a coat, and your medulla is the middle part, and I just always associate that with M and M. Your cortex is composed of 3 different zones, but we call them zonas. So you have your zona glomerulosa, which secretes aldosterone, and this regulates your blood pressure and electrolytes. Zona fasciculata, which releases hormones like cortisol. And then your zona reticularis, which primarily releases androgenic steroids, which stimulate your ovaries and your testes. The middle part is the primary suspect in our pathology case, because this is where your chromaffin cells kind of hang out. Your chromaffin cells make a hormone called catecholamines, and those include epinephrine and norepinephrine, which are your fight or flight hormones. So what exactly is pheochromocytoma? So if we break down the word, it quite literally translates into dark colored cell tumor. This tumor arises when your chromaffin cells start to divide uncontrollably. This normally just happens in one of your adrenal glands. It doesn't really happen in both. It can though, so I would be aware of that. And this tumor can actually arise anywhere in your body that contains chromaffin cells, so that would include like your carotid arteries, your bladder, and your abdominal aorta. These tumors just kind of pop up whenever they feel like it, but they do have associations with some inherited syndromes like von Hippel-Lindau syndrome and neurofibromatosis type 1. So just a continuation of the last slide, when pheochromocytoma develops, it releases too many catecholamines into your blood, and as we discussed in our A&P, catecholamines include your norepinephrine and epinephrine, and so this actually explains why these patients have the same signs and symptoms of those that have panic disorder and anxiety disorders. This can be triggered by stress, exercise, and certain foods that have the molecule tyramine in it. When you have too many catecholamines in the blood, it causes your smooth muscle around your blood vessels to contract, which ends up causing hypertension because your resistance is increased within those vessels. This can eventually lead to ischemia or hemorrhage because those vessels end up breaking because they can't handle the pressure. Over time, this will result in a hypertensive emergency, and this person can develop congestive heart failure, strokes, and eventually kidney failure as well. Pheochromocytoma can spread to different locations like your lymph nodes, which is the most common, but also your liver, bones, and lungs. So what are some symptoms you're going to see with pheochromocytoma? Well, the most common one is high blood pressure, especially if it's accompanied with tachycardia. You're also going to see anxiety, headaches, sweating, palpitations, chest or abdominal pain, pallor or flush, nausea, and then a recent onset of hypertension. However, to differentiate pheochromocytoma from other adrenal tumors, the doctors will primarily look at headaches, sweating, palpitations. It's the triad that they normally look for. They will 100% suspect pheochromocytoma if the patient already had hypertension and then they have these 3 symptoms. So let's talk lab values. So the primary way that they determine if it's a pheochromocytoma versus some other adrenal tumor is by blood and urine testing. So your blood test is going to be your measurement of plasma-free metanephrines and norepinephrines. They are basically metabolites of epinephrine and norepinephrine that's in your blood, and this test specifically is used to rule out a pheochromocytoma or a paraganglioma. The other test is your urine testing, which is the 24-hour collection of fraction, metanephrines, and catecholamines, which is just a fancy way of saying that they're testing for the exact same thing. So your metanephrines and norepinephrines, as well as catecholamine. This determines the amount of catecholamine that you have in your urine, and this test is super accurate, and it determines specifically if the patient does have pheochromocytoma, and so it's the preferred lab that they use when diagnosing it. So now on to our differentials. So just based on labs and clinical findings, the second culprit that they're going to suspect are your paragangliomas, because they are another extrarenal mass and they are very similar to the pheochromocytomas. Heart failure, essential hypertension, anxiety, and panic disorder are also suspected just because of the signs and symptoms. They all have very similar signs and symptoms, but then based on imaging, we would suspect maybe an adrenal adenoma, adrenal carcinoma, myelopoma, or metastatic cancer of some sort. So now on to imaging. So CT is the gold standard for imaging pheochromocytoma, shocker, and then next is MIBG, and then ultrasound. So I wanted to talk a little bit about MIBG just because they do use this type of imaging specifically for pheochromocytomas and other adrenal tumors. So it confirms the presence of neuroectodermally derived tumors, which is just a fancy way of saying hormonally derived. There was actually a woman, I read about a case study of a woman coming in. She had the same signs and symptoms of our guy in our case study, and the CT had actually missed the tumor. However, they were still suspecting that it was pheochromocytoma or a neuroblastoma, And so they ended up doing this exam, and basically what they do is they inject you with a radioactive material, and then they stick you in the scanner, and then it comes out looking like this. And you can actually see the mass right there, and then of course a little bit here, and then I think also in the bladder here, because like we discussed, it'll occur anywhere that you have chromaffin cells. So I thought that was really interesting. CT didn't catch it, but the MIBG did. And then of course on ultrasound you can see all the different appearances of this tumor. It comes in all different shapes and sizes, as we're about to discuss. So as far as sonographic characteristics go, pheochromocytoma can come in a variety of appearances. It's actually really hard to try to pinpoint what it looks like, or to be like, okay, it looks like A, B, and C. If you see A, B, and C, it's probably going to be a pheochromocytoma. It's actually nicknamed the imaging chameleon for this very reason, because of how many different ways it can appear. So for example, you see here it looks acogenic, it's got irregular borders, and it just overall looks really nasty. Like I probably wouldn't have guessed that that's pheochromocytoma. Here you can see that it's got like kind of a cystic looking structure in the middle of it, and then of course the one that we had from our case study with the smooth borders and it being hypoechoic to the liver. And this one also has irregular borders. There were a ton of different pictures in all these different journal articles that I read and looked at, and of course don't even try googling it because you're gonna get like 5,000 different results. It's insane, and it's one of the reasons why ultrasound is not primarily used to diagnose this particular tumor. So as far as treatment goes, the primary way that they treat pheochromocytoma is by surgically removing it. Before they do that though, they will prescribe you a blood pressure medication that blocks the actions of epinephrine and norepinephrine to lower your risk of having high blood pressure during the surgery. They can also treat this tumor with chemo and radiation, but of course they try to avoid that at all costs. But yes, most of the time they will surgically remove it. Here you can see the tumor, and then it's attached to the kidney, and then also here. I just thought they were interesting pictures. And because I'm extra, I included a video of the actual surgery. I highly recommend you go watch it. Unfortunately, I can't play it in this presentation, but please go watch it because it's super interesting. And I know it says it's age restricted, but it's really not. Just click on the watch on YouTube and you can go watch it. It's only 6 minutes long. It's really, really cool. But yes. And these are all the resources that I used. Thanks for watching.